particular so-called episode of tonsil inflammation that you don't want to overlook are people who might have what we refer to as unilateral or one-sided tonsil inflammation, as you can see on this, if you're on your right side. You can see that I think this might stretch all the way. So you can see the uvula, and you can see this tonsil. It's mildly inflamed, but the one on the other side is disturbingly inflamed. And so you don't want to overlook people who are giving you a history of a sore throat that troubles them for a few days. They think they're going to get better. Then they start having pain just on one side, just on one side, and it just progresses. And then they have this interesting feature, I believe I mentioned it the last time, this interesting feature called trismus, which means that they just don't want to open their mouth. So if you see someone who's had a progressive sore throat for several days, one-sided, and have this condition of inflammation of these delicate God-made pterygoid muscles causing trismus, oh, you always have to think of a peritonsillar cellulitis or an abscess. Don't overlook those. If they present that way, they may have some temperature, but it might not be severe. Don't send them home. Say, you know, you have something that's going to progress. It's troubled you now for 5 or 6 days. Let's let someone take a look or have a CT scan and see if there's an abscess. There may not be an abscess. This might be just all soft tissue inflammation. But either way, these people don't do well at home. I believe it's appropriate to hospitalize these people. Get a scan. If there's an abscess, have it aspirated. Get them on IV antibiotics or steroids.
Is there a tongue depressor on his tongue there? Keeping the, because I'm not sure what.
Bottom left.
Right here. Yeah, it's probably some device trying to get a better picture, whether they're using, these are these little plastic retractors that we use to pull them out.
Okay.
That might be, well, I can't say, but the point being is that this is not an uncommon entity. And they don't all have to be abscesses. They can be just a severe cellulitis. Oh, here's our friend, the person who has a progressive sore throat. They're given antibiotics over the phone. They feel miserable. They have no pep or energy. And they just miserable. They're usually a teenager. And it's an entity that is frequently overlooked because, and they might have even these little petechiae of the palate, and we had one about a month or so ago. And it's a great fooler, and that's infectious mono. It fools so many people, and it doesn't have to be always typical. There are honest practitioners, providers, either in family medicine or even ENT, who have to admit that they've been fooled, even in their old age, by infectious mono. They can fool you. They just do a mono spot when you suspicion. The tip-off of infectious mono, they have significant bilateral adenopathy that's out of proportion to just a simple bout of pharyngitis. They have disproportionate bilateral, not unilateral, bilateral lymphadenopathy, both in the anterior and posterior chains. I think we may have covered this because this is an example of someone who has recurrent swelling right below the jaw because they have an obstructed duct. And you can see the stone in the duct. And this is an individual who has a stone in the submaxillary duct, usually calcium carbonate, unrelated to diet, usually related to poor hygiene, being chronically dehydrated, lots of unusual flora in their mouth. They end up with an ascending infection through the duct system that inflames the glands, that produces ridiculously sludgy secretion, and in that sludge, which should be crystal clear, that's coming out through the opening, that crystal clear secretion isn't present. They have sludge, and in that sludge precipitates out a calcium carbonate stone, and they have to be removed.
Outpatient, or can you just do that in the office?
I can do that in the office. It can be done in the office as long as the stone is in the distal part of the duct. The duct runs sort of downhill to the gland, which is down here. And if it's in the first the first half of the duct, I can remove them in the office. The reason we can't keep opening up further and further down is because we unfortunately will cut the lingual nerve, and it ends up with a certain morbidity as far as numbness. So you just don't want to do that. But when they're at that point, you can certainly remove them.
What causes that, Dr. Demarco?
It's usually an adult who doesn't take care of their mouth, smokes, drinks, is constantly dehydrated at times, don't take care of their teeth. So they have a flora in their mouth, which we all have. But the flora that most people have is a balance between what I call good bugs and bad bugs. And there's never anyone who wins the battle. But some people have lousy flora in their mouth. They have just junk in there, and they have junk in the category of bacteria. So they end up with an ascending infection. It literally travels up the gland. And they do that because they're chronically dehydrated and they can't wash out bugs. You wash out bugs from glands in your submaxillary glands and your parotid glands. I wash them out. Yes, bugs want to go someplace. They'll crawl up in there, but they're always getting this onslaught of secretion that washes them out into the mouth. Once it gets up there, it'll start an infection. Instead of making clear sludge, clear secretion, you make sludge. And in that sludge, you precipitate out a stone. I haven't seen anyone with a pristine oral cavity that have stones. Never seen it. Now, in the mouth, we have lots of what you call secretion or saliva. Where does it come from? It comes from minor glands throughout the mouth. You get a little secretion when you eat from the sublingual and submandibular glands and parotid glands. But there's a scattering of glands all over the mucosa, in the floor of the mouth, and on the undersurfaces of the tongue that can become obstructed, and you end up with these nice serous cysts. Here's a good example of a serous cyst here. And they're not inflamed, they're just obstructed secreting glands, and depending on their location, they can affect the various functions of the mouth, such as chewing, eating, swallowing, talking, and just the fact that there's a certain unusual fullness and they can see something in the mirror at home in the bathroom, so they have to be removed. And they're simple to remove because they're entirely benign and the material is never infected in nature, but it has to be opened up significantly so that as it heals, it scars in and it doesn't prevent these glands from obstructing again. But one of the most common ones are the ones that you see on the lip. This is a good example of a traumatic inclusion cyst of the lip. And it'll grow, it'll be very evident. It doesn't affect lip function, but it comes about by people who might bite their lip. The lip has numerous secreting glands. That's why it's not dry. If you run your tongue across the inside of your lip, it's not at all dry. It's wet. Where's the wetness come from? It comes from numerous secreting serous glands. Well, if you traumatize a bunch of them and they can't secrete, what happens? You end up with a cyst, and that should be removed. Just pricking it with a needle is never going to satisfy it because it'll form again. It has to be excised carefully, not to compromise any of the natural structure of the lip, the fullness of the lip, because then you have sort of a cosmetic disturbance. But the lip is very forgiving, but it has to be removed. Tori are very common. These are exostoses. They're not a problem. They mature and grow to a point when people are about 18, 19, then they stop growing. The only problem they don't affect our speech functions of our tongue, but they can be a problem for the dental professionals if they have to do such things as reconstruct a plate, a full plate. Pretty hard to put a plate in someone like that who might need an upper denture because of that, or particularly in the mandibular area. But they're sometimes totally asymptomatic, and it's surprising the number of people who have these who don't know about it, except it's mentioned occasionally when they have the dental hygienist clean their mouth.
How common is that?
I would say they're relatively common, because sometimes they can be very small.
Because that one, I mean, you would think because your tongue rests on the roof of your mouth, like, why wouldn't that just drive you nuts? Like, I can't imagine, like, feeling something super bumpy up there.
It's because of the level of tolerance our tongue has. Think of our tongue as it moves around and the fact that we don't bite it as often as we do. The clearance between our mouth's opening and closing and the tongue getting out of the way is just almost miraculous. It gets out of the way, and yet it's just a few millimeters when we close our mouth. So it tolerates it. Now, if it was rough or opened, or if there was little spicules of bones from this exostosis, then the tongue would know about it and would kind of remind you. Otherwise, you kind of tolerate things.
So remove those.
Those are removed if the dentist says they have to do something as far as a plate. Otherwise, we don't. They're relatively easy to remove because it's just a drill that cuts through this bone, and then you just let it epithelialize over again.
Which specialist usually takes those out?
Well, we do, but of course the oral surgeons are constantly invading our territory, so they probably do it. And I would let them do it.
Battle.
Now, this is a burn of the, I can't remember, I don't think we showed this before, I always forget. This is not uncommon. This is what is referred to as a pizza burn. People biting down on a big, juicy, thick slice of pizza that has this extremely toasty, very, very warm cheese on top, and it sticks just like bubble gum. And they can get a good burn of the palate. They'll get it off there, but then they've lost a modest amount of mucosa, and it has to heal. It's painful. Well, it can be painful for up to a week. Pizza burns are not uncommon.
Is it just topical kind of anesthetics to treat it?
Anything in that category can be used. It can be. Any of the lidocaine preparations can be used. Now, sometimes we'll bite our tongue and it heals just within a day or two, but sometimes as it heals, it leaves this bit of granulation tissue, as you can see here. And that gets sort of in the way of the tongue function. Sometimes those are so large and so they're reparative. They're trying to repair, but they don't. They just need to be removed. And then the vase cauterized to see if we can heal rather smoothly rather than this accentuated healing response of the tongue, just a little granuloma of the tongue. Most tongue bites don't result in granulomas. The tongue is absolutely remarkable in its healing ability from any simple bite. The only trauma to the tongue that ever requires any suturing are people who have a severe bout of epilepsy that would bite their tongue and tear into some of the vessels from the lingual blood supply to the tongue. Otherwise, it's very tolerant. There's some people that bite their cheek out of habit. They're cheek biters, and you can see this. And they'll traumatize this. They'll traumatize it. They won't end up with bleeding, but they'll end up with this traumatic hyperkeratosis. And they get into the habit of biting their cheek. It doesn't really result in anything except this particular finding. You don't end up with any tear in the mucosa, but it's not uncommon. There's some people who have all these, I suspect you categorize it as some subtle mental health disturbance. They just love to constantly relieve tension by biting their cheek. Obviously, they just need to know the cause of it, whether or not they correct it. Depends on, I guess, the extent of their anxieties, and then that's up to the individual primary provider as to whether that should be treated or not. Every once in a while, we get a call from a mother that will say their child was running with a toy and it was in their mouth and they fell over and they lacerated their palate. Not uncommon. And they can really get a nice jagged cut in their palate. And sometimes there'll be a little bit of bleeding. It can look kind of awful. It's sometimes difficult to tell parents, just leave it alone, it'll heal. Well, there's a hole there. Just leave it alone, and we'll look at it in a week, and we might not even be able to find the hole. I've never repaired palatal lacerations from children running with a toy in their mouth. I think there's a greater danger, a general anesthetic, to repair a palatal tear than just to let it heal on its own. And they can be significant tears. but seldom is there any significant bleeding. It can be most often on the palate, seldom on the hard palate, but on the soft palate. I don't get too concerned about some particular healing process that then affects palatal function, that then in turn affects their ability to speak with perfect articulation. It never excites me. Now, every once in a while you'll see someone who has a very poor oral cavity. And here's an example of this granular reparative lesion right here caused by that. Caused by a restoration that probably was probably set on perfectly, but has lost maybe some of the components of the restoration, and you end up with these little sharp amalgam points that literally disturb the tongue, and they end up with a chronic sore of their tongue. And as you look around, you find out the obvious cause is a tooth that needs to be attended to. Otherwise, you're going to continue to have this traumatic effect onto the tongue. Always be mindful of the fact that any granular lesion, particularly on the tongue, is always potentially suspicious for a carcinoma. But when it's obvious that the dental that there's a dental involvement, then certainly have one of the dental professionals look and see what they need to do, because there's a constant contact between the tongue and teeth, and if there's a sharp edge on a restoration, you'll start to do a certain amount of traumatic damage to the tongue. You're going to see older people that have what I call this angular cheilitis. And they're usually people who are older, who've lost some of the natural facial support, muscular support of their face. They're usually people who are edentulous, might have plates, and people who lose some of the natural closing activity of the circular muscle in their mouth, so they're always leaking at the angle of their mouth. And that stays moist, and that moistness creates a fungal infection. And it's surprising how these people respond, at least in the standpoint of treating it, with something just as simple as over-the-counter Lotrimin. And then, of course, if there's a disturbance with their dental plates, to have that addressed. But sometimes it's chronic in elderly people. It's fungal angular cheilitis. It's and the tip of it is you might give them a topical antibiotic to use, and it doesn't improve because it's fungal in nature. It's very common. Just one of the Candida species usually responds to topical antifungal cream that they use. It'll clear up, then come back, and then they'll use it again. Sometimes it's more one-sided than the other side, depending on the amount of moisture that collects at the angle of their mouth. Here's our old friend herpes simplex, which the only question we're often asked is, oh, can't this be canker sores? No. Canker sores don't occur on the skin. And canker sores don't occur on the lip. Canker sores occur in the mouth, usually on mucosa that's relatively tight, and it doesn't present with little vesicles. So herpes simplex usually presents with little vesicles that then burst and become crusty and slightly inflamed. And you see people with this. And if you see it in the mouth, it's usually on loose mucosa. And this is real loose mucosa, in contrast to aphthous ulcers, which tend to be on tighter mucosa further back in the gingival buccal sulcus and on the palate. You don't see herpes simplex too often back there, but you can, depending on whether or not it's more than just simply herpes simplex. You can have zoster in the oral cavity, herpes zoster in the oral cavity. And sometimes there's other manifestations of zoster, whether it be the seventh nerve that affects the face, facial paralysis, or if it could be the third branch of the maxillary nerve. And these people have ulcerations that are really significant and painful. But there's other manifestations in these people of shingles or zoster. And obviously they can be miserable people, particularly if they have zoster of any of the cranial nerves and have to be treated rather vigorously with antivirals and steroids. It can happen in the oral cavity, no doubt about it. And of course, as you can see, it doesn't cross the midline. That's another tip-off of zoster. It stays in that particular confines of that nerve supply. Every once in a while, you'll look into the mouth of an older person, and you'll see something on the back wall that's hard and raised, and they have no complaints. And you look at the mucosa. The mucosa appears to be fine. It's just nice vascularized mucosa, no complaints. And it actually represents an osteophytic disturbance of the spine that projects through the back wall, which is nothing more than a sheet of mucosa and associated fibrous tissue, and it presents in that way. And it's not uncommon. Someone who has real severe degenerative disease of the cervical spine can have manifestations on the back wall of the pharynx. You'll see these little raised areas, totally of no complaints to them, but you'll see these osteophytes presenting through the mucosa in this manner. You might say, well, they continue to grow. Well, it depends on the amount of destructive degenerative change they have in their spine, but it never affects functions of the oropharynx in terms of respiratory effort, speaking, swallowing. That's not a factor. This is something that's not uncommon, but you will see it, and sometimes it's something that you might see because one of the dental professionals might see it and then have them come to see a family medical provider. And you see the secret of this is that it has a net-like arrangement of little strands of hyperkeratosis, and it's called, because it's a net, it's called reticular, meaning net. It's called reticular lichen planus. It's an autoimmune disease. There's cutaneous lichen planus, and this is asymptomatic, and it goes through it may fade and then come back again, and then fade and come back as a little plaque. It can ulcerate, but it's uncommon. It's to ulcerate or get terribly plaque-like, but it's not an uncommon entity. It's asymptomatic, and when you immediately see it, you say, well, this could be leukoplakia. But the tip-off is it has a net-like pattern, and it's usually bilateral. So you say, well, this looks like a net, and it's asymptomatic. It's most likely reticular lichen planus. It's not, you don't treat it. It's nothing that you treat. We talked about dental conditions reflecting about how compliant patients are, but as a medical provider, you're going to have people who may not say much to you or have many complaints. They've got horrible looking teeth, but every once in a while, and it's not uncommon, these neglected teeth will then abscess, and they'll have significant pain, usually in one of the quadrants, either the mandibular quadrants or the maxillary quadrants, and it's just a nasty bit of pain. You might be fortunate to come up with an evaluation. You see teeth, and lo and behold, you see what is referred to as these periapical abscesses that have broken through bone and present on the inside part of that alveolar ridge. This is not uncommon. Lots of pain, poorly evaluated teeth, localized over several teeth, usually posteriorly in the area of the molars. And sometimes, not always, but you may just palpate back there and feel some tenderness, but every once in a while you'll find where it broke through, you'll actually see a draining apical abscess. Obviously, those individuals need to have one of the dental professionals see them. And you might say, what do the dental people do? Well, sometimes the teeth need to be extracted, but depending on the status of the tooth, sometimes they can drain the abscess through a root canal and save the tooth. Not always, but sometimes teeth can be saved, but you can't save it if there's any inflammation in the root of the tooth.
Do you put them on antibiotics just to treat?
Well, you might. I'd definitely put them on antibiotics and make sure they see one of the dental people. Even if you don't see something as florid as this, if they just have lots of pain, and you look in there and you say, well, you've had some work done on your teeth, or maybe they might have had a restoration that's broken off, and you're really suspicion, well, they had a restoration, it's no longer there, so maybe the pulp is inflamed and it's gone down to the root. I'd put them on antibiotics and insist that they see one of their dental people and have them evaluate that. This is, dental pain is, as you know, if any of you have had any, it's 24 hours a day. You have pain. And it doesn't go away at 2 in the morning. This is our old friend angioedema. And probably all know one of the most common causes of angioedema that bring people to the emergency room is ACE inhibitors. Probably 40% of the people that present with angioedema in emergency rooms are from ACE inhibitors. And usually it's lip, tongue, but it also can be larynx as well. You have to always be mindful of that. Just this individual is just confined to the lip structures, but it could be much more significant than that.
So is it an allergic reaction, or what's the pathophysiology behind the lisinopril
Yeah, it has to do with
causing it?
these bradykinins and all the mechanism of inflammation that comes from these agents that create these agents are disturbed, and don't ask me all the technical aspects I do, but it creates this rather rapid vasodilatation where fluid can pour in. And if it pours in on the lips, it's unsightly, but if it were to pour in around the larynx, it could be catastrophic. So it's best that these people are seen in their something should be undertaken to establish the status of their larynx, particularly if they're hoarse or have respiratory distress. It could be really significant.
Do we have
I think that kind of.
Treat that. So what would you do for this person?
Well, depending on if it's just in the lip and nowhere else in the mouth, they might respond to some antihistamines. But it'd be wrong for me to say, oh, it's just going to be on the lips, go home. These people, I think, should be treated with epinephrine.
I had one at the base, and she had the lower and the upper. We did put her on the epi.
Yeah, I've got to give. Yeah.
Angelina was just talking about doing racemic epi, and I guess you could do that. We didn't do that in the clinic, but it was with Dr. Finley, and she had both. She had upper and lower. Both her lips were just swollen. Couldn't even recognize the lady. Huh?
Yeah, normally, like if we had time, we would just give them like a epi injection. But if they came in and they were maybe having swelling, like actively short of breath, respiratory was in there already, and administering like they were doing epi. So I
Yeah,
don't
it
know.
can be significant. Yeah.
Here.
Yeah, right now.
Yeah, it can be significant. I think that kind of completes the ones I have in this series. Any questions that I can?
These are really good, Dr.